Hello everyone, and it's nice to be back. You are here at the Chris TV Conversations in Mumbai 2024. My name is Dr. Abad Khan and I'm an interventional cardiologist practicing in St. Joseph Hospital, Ghaziabad. So today we have a very important personality with me today. We have Dr. Anand Rao sir, who is head of Department of Leelavati Hospital, Mumbai. Sir, welcome to the Chris TV. Tell me, sir, a few things from your wisdom and experience that how has the complex angioplasty and complex PCI evolved over the years and what lies ahead in future?
Thank you very much, Abad, and it's a pleasure to be here. Complex intervention has evolved quite leaps and bounds. When we started doing angioplasties, even an osteal LED was a no-no for doing an angioplasty, and that patient we should go for surgery. Well, from there we have come to doing left main, complex left main interventions, the distal left main, bifurcations, CTOs, whatnot. So the complex intervention has moved into a different direction, and it's been done in most of the places because of the facilities now being improved. For example, the imaging, which has been a significantly increased over a period of time, and that has helped us to understand whether it is a true complex or it is not a complex. One thing. Second thing is we have understood how to preserve and protect each and every branch. Earlier, when there used to be I'm talking about almost when bare metal stents were there, when there used to be an LED diagonal lesion, most of the time we didn't even have a concept of putting a wire into the diagonal. So all this most of the time the diagonal is to vanish and just the LED is to stay. But over a period of time, we have understood how all these things will contribute for residual ischemic symptoms and so on and so forth, creating MACE long-term outcomes which are not very good. So yes, now there's another terminology which is called as CHIP, CHIP, complex intervention procedure, which is a planned procedure where you use impella, mechanical circulatory support system, and then you try and revascularize all the arteries. I mean, if you have a CTO, you can do CTO. If you have a retrograde, antegrade CTO, you finish that. You do left main, rotablators, everything you can do. And with this impella kind of device, you can get away with most of the cases. So, complex interventions has evolved. And of course, it has the atherectomy and the calcium modification has taken a big kind of step. And more devices are coming into calcium modification, which I think people should get trained, and they're getting trained, and we are able to deliver good results. So complex intervention has evolved, and yes, we are like certain operators, we are called for only doing complex intervention at certain places, and I personally go as a proctor to various places to guide them and to do complex interventions.
Great, sir. It's great to learn from that sir just pointed out, and I'll just briefly point out that the facilities have changed and the education and the understanding of the disease has also changed immensely to contribute for that. So the second question is that the younger cardiologists like myself also, so they are trained in imaging these days, they are trained in active and passive exposure, have the interventions also. But still, sir, some people have met with complications and they develop fear. How do you plan to circumnavigate those fear via this CRISP conference to these younger age cardiologists, sir?
Here we are going to deal with a very important thing. CRISP, this is going to be our important point to educate people and to go with foundation messages so that they learn and practice very well in their clinical course and then deliver good results. Now, the foremost thing in any other field, you need training. You need proper training. The training is important because now the structural heart is evolving so much. A formal training is required. Like for example, when we came as a coronary interventionalist, we worked under people for a couple of years. That's how we were able to establish ourselves as good interventionalists, and then we are delivering our results right now. Structural heart has to be like that. You cannot just go and do a TAVI on your own. It's not allowed. You need to undergo training and then do first few cases with the proctor, maybe 8 to 10 cases with the proctor, and then understand the nitty-gritties of this and then go ahead. So, but structure is myriad. It's just not TAVI. Now we got aortic regurgitation treatment with TAVI. we have mitral TMVRs, and we got now dedicated valves for mitral stenosis and tricuspid regurgitation.
Yes.
So this is getting evolved. Now more and more focus is being given to tricuspid regurgitation and tricuspid stenosis and so on and so forth. Apart from that, left atrial appendage closure has become very big and favorable results are coming out of it. So this is going to be very, very important. So to get out of the fear, the only thing is practice, practice, practice. First few cases do not do individually, and if any time you find any problems, there has to be a proctor standing over them and guiding you. So this hands-on training will benefit. This is what in CRISP we are going to do. We are going to provide a hands-on training for all these upcoming cardiologists, younger cardiologists, so that they do this good clinical practice in their private practice.
Thank you. And the greatest answer couldn't have come from anywhere else. As sir feels, the training is the utmost important thing that is the only thing that can alleviate the fear among the new age cardiologist. And sir, also I'd like to ask that the world has shifted. You have seen the world shift yourself from balloon angioplasty days to a drug-eluting stent, and now from femoral approaches to radial interventions. Where does, sir, the drug-coated balloon stands now, and what is the future for this drug-coated balloons for the future, sir?
Right. I come from the era where I was doing interventions before the stents came in, what we called it as plain balloon angioplasty. And then bare stents came, then bare metal stents came, then drug-coated stents, then drug-eluting stents. Now we are coming back to basics, what is called as drug-coated balloon. So we are going to, what we started as plain balloon angioplasty, now we are coming as a drug-coated balloon. So what is this difference? So there are several advantages of doing a drug-coated balloon in a properly indicated case, so that you don't leave anything behind. You don't have metal behind. Advantage is you can stop the antiplatelets as early as possible. And plus, if the patient has some surgical interventions to be done or something like that, you can do a drug-coated balloon, we can finish it off. But there are specific indications. Something which comes should not be taken overboard. It should not be like a herd mentality. If X person is doing drug-coated balloon all over the place, you yourself can do it. No, there's a learning curve for this also. So, according to me, the best indication for drug-coated balloon is instant stenosis, where you don't want to put another stent. That's the first thing. Prepare the vessel, open it nicely, finish off the therapy with the drug-coated balloon, and come out. That's the best therapy. Second is diffuse distal disease, where you don't want to put a stent or you want to preserve that vessel for future bypass surgery. You can do a drug-coated balloon and come out. Another indication is side branch. When you do a bifurcation stenting, you don't want a metal load and you want to leave that artery with the less metal load. You can do a drug-coated balloon and you come out. These are 3 indications for drug-coated balloons. Proximal vessels, according to me, there is no data, and I think we should still be away from it. But this has to be understood. So they're coming out with good results and good trials, but we need more head-to-head trials in the proximal vessels.
Great, sir. As sir already told that the data, the indication, and the uncaging of the coronary arteries. To hear from sir more, please do join on CRISP 18th October to 20th October 2024. Sir, thank you.
Thank you.